All right, welcome everyone. My name is Chelsea Andrews. I am one of the Michigan Value Collaborative Site Engagement Coordinators, and I look forward to facilitating this work group today. Today's Health and Action work group is featuring a presentation by Heather Owndahl, the Program Manager of the Fellow Collaborative Quality Initiative, the Michigan Mental Innovation Network, and Clinical Design, also known as MyMind. Heather and the MyMind group work together as a state partnership with providers to prevent suicide, improve outcomes, and reduce costs. The focus is on evidence-based services, starting with suicide prevention and expanding to other behavioral health domains. As an experienced program manager, Heather's background includes work in the Mental Health Service Corps, part of the University of New York, the Primary Care Information Project at the New York City Department of Health and Mental Hygiene, and the American Lung Association's NYC Asthma Coalition. Working with collaborative care initiatives across New York City, she has provided project management support to increase access to mental health services within primary care outpatient clinics. Her experience also includes working closely with health system leadership on quality improvement initiatives for inpatient and outpatient settings. Heather has also acted as director of a quality collaborative to launch several pediatric asthma improvement projects, trained and supervised health education staff, and hosted events for the coalition. She has her master's degree in public health from the Icahn School of Medicine at Mount Sinai, New York, and Heather's study emphasis was in epidemiology and biostatistics. Her role with MyMind includes program administration, strategic partnerships with other CQIs at Henry Ford and U of M, at Michigan Medicine, including MVC, and operational oversight of the coordinating center team and engagement with other physician organization leadership for collaborative participation. Thanks again, Heather, for joining us today for the work group. Before you begin, I just have a couple housekeeping items to review for everyone. As a reminder, we do record our work group sessions. The recording and the slide will be shared with attendees following the work group. We ask that you maintain muted throughout the presentation, unless of course you are Heather. And then we will ask that you hold on to questions for the end. You're always welcome to put them in the chat as well, but we will have time to answer with a Q&A after the presentation concludes. I also ask that, just for everyone's awareness, since we are a largely CQI-based work group today, we would love to have everyone put in the chat your name, title, and the site that you're from, just for everyone's awareness, so we can keep an eye on who's participating today, and that would be helpful for answering questions at the end as well. And then, of course, with MVC, we appreciate your feedback. It's very important to us. So if you could, please complete the post-work group survey that will go out with the follow-up message. The email will be sent following the conclusion of the work group, and we would love to have your feedback for consideration in future work group topics. So with that, I'm going to move on to your presentation, Heather, and I'm going to spotlight you, and you are welcome to get started.
Okay. Well, thank you so much for having me today. I'm really thankful to be here. I think that, this month is Suicide Prevention Month. And it's just been a great opportunity for our team to get to work with a lot of different communities, talk about it with providers. And I think this is a good opportunity to do this too. So we are going to talk about suicide prevention today, since that is our first initiative. And I know it is a tough and sensitive topic, but an important one. So just please be sure to take care of yourselves. And if you have any questions or need any support afterwards, just let us know. So thank you. All right. So next slide. Okay. So just really quickly, I'm going to give a brief overview of what we'll be covering today. So in large, you'll meet our team. I'll talk a little bit about them. We will also be spotlighting the work of the CQI as well as the Zero Suicide Initiative and how it functions. And then at the end, we will make sure to leave time for questions. Next. Okay, so first let's meet the leadership team. The MyMind CQI is co-directed by Dr. Brian Amadani and Dr. Kathy Frank. And as a way of introducing them, both Kathy and Brian were some of the early implementers and evaluators of a suicide prevention program at Henry Ford, which led to international interest and commitment to eliminating suicide through the zero suicide model. Kathy is the principal author of the suicide prevention guidelines that were central to earning her the Codman Award, the Joint Commission's highest honor, and the American Psychiatric Association's Gold Award in 2006. And Brian is the Henry Ford Health lead PI for several NIMH and NIH studies that have led to several key research findings related to healthcare access patterns before suicide and evaluation of the zero suicide model as the gold standard for evidence-based prevention. And then obviously you just met myself, but I'm just very thankful to be a part of this team and bring previous experience to the role as program manager. And then finally, I would also like to highlight my colleague Amanda May, who is a licensed social worker and the training director for My Mind, and is also the Behavioral Health Collaborative Care Operations Director at Henry Ford. So she brings her experience partnering with primary care physicians to provide guidance, training, and resources to everyone within our mental health collaborative. Next slide. All right, so now to meet our team. I honestly could go on a lot about each of these people. They're so passionate about the work that we do, and each brings such unique expertise and insight. But our team is comprised of a committed and passionate group of clinical trainers, data analysts, scientists, and operations staff who are passionate about our mission for suicide prevention. And our team works really cohesively to develop each aspect of the Zero Suicide Initiative, from training to user access to program engagement. Next slide. Okay, so just really quickly, like we mentioned, we are a mental health collaborative. And just to think a little bit about our overarching goal for our collaborative, we really do want to focus on the pain, morbidity, and mortality of mental illness in the state of Michigan, and work with each of our collaborative mentors to figure out how we can innovate and come up with good solutions based off of their practice. As mentioned, we will also be focusing on our initial goal, which is to prevent suicide deaths and attempts in the state of Michigan through our Zero Suicide Initiative. Next slide. Okay, so why focus on suicide for our first initiative? So just a little bit of background. More than 48,000 people die of suicide in the US alone. Approximately 1.4 million suicide attempts occur each year, making it the #1 cause of injury-related deaths, and the 10th leading cause, with an increase rate that has jumped to over 25% since the 2000s. And in addition to that, has also had a tremendous financial impact on the health systems and communities that we serve. Next slide. So how are we going to reduce suicides? Well, we think it's really important to focus on a two-pronged strategy to reduce suicides. By really focusing on the partnership between primary care and behavioral health to develop a collaborative clinical model. So training primary care and suicide prevention is critical to reduce suicide deaths and attempts. And the research indicates that 83% of individuals who die by suicide and greater than 92% of those who attempt have had a healthcare visit within months of attempt, and many of those visits are not to behavioral health. Only 33% of those who die by suicide have ever had a behavioral health visit, which really highlights the importance of detection in other settings where people are most likely to be receiving care. Next slide. So we know that the stigma related to mental health and suicide continues to be an issue in this country and globally, and it is crucial for health systems, the government, and the general public to band together to normalize the process for individuals to get support and seek resources and care they need when they are in crisis. This is why we need a systems approach to truly prevent suicide. We came across this graphic from one of Dr. Frank's presentations related to zero suicide, and I think we really we really like it because it helps us think about just the cultural transformation that needs to happen around suicide. So as you look at this graphic, maybe just start to think about where you or your organization are within this work on this iceberg and what it would look like to get to the next step. Next slide. Okay, so what is zero suicide? At the core of the zero suicide model, it is a quality improvement initiative for safer and more effective suicide care in healthcare settings that came out of a call to action developed by the Office of the US Surgeon General and the National Action Alliance for Suicide Prevention. The zero suicide model is based on the work and research of a team at Henry Ford Health, right here in Michigan, and they believed that deaths by suicide are preventable and introduced their goal to reach zero suicides back in the early 2000s. So, just really quickly to address the elephant in the room, are zero suicides possible? Well, as Dr. Frank has been quoted, it's important to reframe by thinking, what if your family member or spouses felt the same way? What if that they felt that it was too much effort? Wouldn't you try to do everything that you could to help save your loved one from dying by suicide? So what if using a 10-minute intervention or having a brief conversation could save someone's life? So I think when we look at it this way, it's more than worth a try, right? You'll see as I go on in the next couple of slides that we do not expect that this is a change amongst just the participants on this call or within members of the My Mind Collaborative. And our hope is that we are all a part of the social change needed to happen within healthcare. And really just our society at large to reduce and stop deaths by suicide and normalize conversations around mental health. Next slide. So just to dive a little bit further into our core values for the Zero Suicide Initiative and talk a little bit about its history and successes. The Zero Suicide Initiative includes leadership driving cultural transformation related to suicide prevention within the agency and health systems that you will work at, but also in a society at large. Of course, we recognize this is incremental and a long-term goal, but leaders starting to put processes and protocols in place to keep patients safe is the first step. Timely access to care that meets the patient's need is also a core value. We know that you may not always be able to get a patient in for behavioral health treatment that day or even that week, which is why, in my mind, we want to provide participants with more tools to be able to support and care for patients with suicidal ideation in real time. And we work to help strengthen care pathways to support referrals and linkages to care. In addition to that, the alliance of patient and clinical team is also imperative to the initiative. Meeting the patient where they are, being open to hearing the patient out using active listening, and letting them know that you care and want them to be safe as possible can go a really long way. Continuity of care and shared service responsibility is another pillar of the Zero Suicide model, as we recognize that if we only focus on suicide prevention and behavioral health, we will be missing a lot of people and will be unable to meet our goals. And then finally, a shared responsibility to prevent patient harm and suicide amongst all the providers that a patient touches is so important for continuity of care, especially between providers during a referral or a warm handoff. We want to make sure that our performance related to suicide prevention is evaluated and that we use data analysis for further quality improvement to strengthen the zero suicide practices and help us get to our mission of zero. Next slide. Now to touch on the strides that have been helped us get to where we are today with the My Mind Collaborative. So just in brief, in 2001, a team from Henry Ford Health, Behavioral Health Services started the Perfect Depression Care Program with the bold goal of getting to zero suicides. Through the 2000s, the research evolved to incorporate suicide prevention strategies into every level of the health system and led to a reduction in suicide rates. Research eventually expanded to include health systems outside of Michigan, and in 2011, the National Action Alliance was formed to create a national strategy to reduce the number of suicides to zero, and this was later adopted by SAMHSA and the Suicide Prevention Resource Center, SPRC. So with the research to support the numbers, the Zero Suicide Initiative became the first program in the US that was linked to decreases in suicide among behavioral health patients. This has since launched the Zero Suicide movement. Over the last 20 years, adoption of the Zero Suicide model has led to successes in Michigan, nationally, and now even globally. As a part of the team that started the Perfect Depression Care program at Henry Ford, Dr. Brian Amadani and Dr. Kathy Frank recognize that we have a long way to go to increase community access to zero suicide. And a demand for zero suicide strategies locally fueled both of our directors to apply for the CQI program through Blue Cross in the Value Partnerships program. And it is the first statewide CQI that's really focused on behavioral health and making sure that we put behavioral health on par with physical health. Next slide. Okay, so like I mentioned, Brian and a group of our team was also a part of a large research study. And this graph has a lot of information on it, but I'm going to walk you through it. So now just to quickly pull us back, as mentioned, it was found in an NIH longitudinal research study that nearly all individuals who died by suicide received healthcare in the months prior to their deaths. And the most common visit types for these individuals were medical specialty and primary care visits without a mental health diagnosis. These findings present an immense opportunity for suicide prevention to take place in primary care and medical settings where patients are most likely to receive care prior to attempt. And targeting efforts to improve identification of mental illness and suicidal ideation will prevent a large proportion from remaining undiagnosed and undetected prior to death. So just really quickly, what this is really indicating is that a lot of patients prior to suicide death were actually accessing care in other areas outside of behavioral health services. All right, next slide. Okay, so just to further reinforce that point, this slide shows that by focusing on suicide assessment and adopting suicide prevention measures through the healthcare system, Henry Ford saw a dramatic decrease in suicide rates, with zero suicides in the health system in the year 2009. Henry Ford has been able to maintain that reduction in suicide rates since 2001 and continues to work towards the goal of zero suicides, which is why Henry Ford Health is also a participant in the My Mind CQI. And for many of my clinicians, you're probably looking at this and seeing that it ends in 2011. So just as a note, the most recent paper should be coming out sometime in the early part of next year that shows the successes of model fidelity. So that's something that Dr. Brian Abdani is a part of, as well as other members of his research team across the nation. All right, next slide. So how does My Mind implement our Zero Suicide initiative with our collaborative members? Okay, so I want to touch a little bit on what it means to design for zero. So most likely you're aware that Michigan is the home of Motor City. Many of us may be based in Detroit, we are. And you've probably also taken a plane in the past, and some of you may even live close to a nuclear power plant here in Michigan. So now what if automotive, aviation, or nuclear power plant industries did not design for zero defects? Would we feel comfortable buying a new car or a plane ticket if we did not feel that they were designed to have zero defects? Would people even be able to live in those areas if the nuclear power plants were not designed this way? So if we expect this in those industries, why not hold healthcare to this standard? At My Mind, we believe that we can design for zero, and we know that this will take a lot, but we also believe that it is possible. And I know that what you might be thinking, that this is not leaving space for human error, which we understand. Some of you still might not feel won over, and that's okay. At My Mind, we do like a challenge, and we're glad that you're here and want to learn Okay, now for the ask. We recognize that suicide prevention is everybody's business, but it is important to be clear on our recommendations. So for primary care, we recommend screening for suicide risk at every visit with a PHQ-9, assessing for imminent risk, and a warm handoff to behavioral health will provide a risk assessment. I'd also like to note that in our CQI, we also provide resources and training on grief interventions for primary care because we believe it is important for providers to be aware of risk factors and protective factors and to consider when behavioral health is not easily accessible. And then for behavioral health, we recommend partnering with primary care to provide a risk assessment after identification, completing a risk assessment at every visit, and initiating treatment to modify risk. Next slide. So why the PHQ-9 as the suicide risk screening tool? So the research indicates that patients that respond with 2 or 3 to question 9 account for more than 50% of all suicide attempts and deaths within 2 years of following a positive screen. The research also indicates a 2 or 3, so on the Likert scale of 0 to 3 on question 9, increased risk of suicide attempt is 5 to 10 times within 30 days and 4 to 7 times within 90 days. We also like to note too that there is a near negligible increase of same-day suicide with a positive screen. And 2.9% of patients score a 2 or 3 on question 9 in primary care populations. So there are some safeguards that clinics can put in place when using the EMR for screening, such as sending the questionnaire out 48 hours prior to a patient's appointment and putting wording in the screening recommending that the patient go directly to the ER if they are in danger of killing themselves. We also suggest that clinical staff contact the patient same day if they're new to the clinic and the patient screens 2 or 3 on question 9. And if they are an established patient, the recommendation is for clinical staff to follow up within 48 hours or using best clinical judgment. Next slide. I know that many healthcare providers are familiar with the Framingham Heart Study. Many of us have probably reviewed that in previous courses, and risk model, and possibly the research that's behind it. Just to keep it short and sweet, this study is related to research on screening for risk factors and stratifying risk for cardiovascular disease. And this was an iconic, multi-generational, and longitudinal study that found that the Framingham score can be used to help physicians quantify risk and guide preventative care related to cardiovascular diseases. The study found 20 to 30% likelihood of coronary heart disease, and for a patient with the highest risk factors or in the highest risk bucket. This research changed the way that healthcare provides screens for CV risk and the care that they provided to patients at higher risk for CV issues. It is why in routine physicals, doctors check for high blood pressure, high cholesterol, unhealthy eating patterns, smoking, etc. So at my mind, we have adopted a very similar approach to the suicide risk model using the PHQ-9 for screening and suicide prevention. Research demonstrates that the likelihood of a person having a suicide attempt or dying by suicide during a 2-year period after a positive score on the PHQ-9 question 9 is 50% more likely, again showing that longitudinal risk. My mind is utilizing the PHQ-9 as a gold standard of care, and like the Framingham risk model, the pioneers of zero suicide, in my mind, created an assessment and guidance for next steps based on research that has been done on the PHQ-9 and risk factors for suicide, which we'll touch on in a second. Next slide. So the key to the zero suicide is to identify risk and to modify risk. We suggest screening every patient at every encounter because it may not be as evident to the provider how a physical illness or behavioral symptoms are affecting a patient on any given day. For this reason, we also suggest that behavioral health does a comprehensive risk assessment. Ideally, primary care administers the PHQ-9 or other suicide risk screening and puts processes in place to automate and streamline their practice so that every patient is screened at every encounter. If a patient is identified at risk for suicide, primary care screens for immediate danger, plan and intent, and a warm handoff is made to behavioral health. We do realize that access to behavioral health can be limited, which is why it is important for primary care to know the risk factors that may cause the patient to be at higher risk, as well as what protective factors can be added and considered to help the patient be safer in the interim. Next slide. So just really quickly, the way that we organize how suicide risk is into 4 evidence-based categories based off of risk. And those include acute risk, high risk, moderate risk, and low risk. And we'll touch on that more in a moment. All right, next slide. In addition to that, I previously mentioned that there are certain protective factors to consider as well. And some of those are safety planning, access to psychiatric care, as well as really thinking with the patient about reasons for living. So whether or not that's support people or family, spiritual beliefs, coping skills, presence of a support system, parenthood, relationship with a treatment team, individual meaning of suicide, fear of suicide, no acceptable methods available, or belief that suicide is immoral or will be punished. Next slide. So on this slide, you will see that the risk factors that are considered considered for acute risk. For those of you that provide direct patient care, it's important to really look at these. And so one thing that we like to note from Dr. Frank and Dr. Amadani and the behavioral health team at Henry Ford is that they've worked to make the risk buckets as clear as possible and to ensure that the risk stratification is evidence-based. It's also important to recognize that a patient is considered acute risk for suicide if they present with suicidal plan or intent, have a history of suicide attempt in the last 30 days without intervening mental health treatment, or if the patient has severe hopelessness, current uncontrolled mania, or current psychosis with command hallucinations, and or severe paranoid delusions. As Dr. Frank often says, these should be very clear warning signs that a patient needs to be hospitalized. If a patient presenting with any of these symptoms is not hospitalized, there should be very good clinical reasons and considerations for safety in place that justify the decision not to hospitalize the patient the same day. All right. One thing we also like to think about is how important it is for providers to work together outside of behavioral health, especially with primary care physicians, to be aware of zero suicide recommendations and be able to do some intervention with patients before they leave the office, such as providing the 988 suicide and crisis lifeline information. And it's also important that primary care and other specialty providers outside of behavioral health communicate to ensure that they can support each other on interventions such as assessing and supporting removal of lethal means and involving family, and that they are aware that these interventions are proven to reduce suicide risk. My mind is also supports primary care physicians to feel more comfortable and confident to provide these interventions when there's a lack of access to behavioral health, or even when patient refuses behavioral health treatment. We also provide a platform and opportunities for behavioral health and primary care to coordinate and collaborate within and outside of their POs to build stronger partnerships. Next slide. So I like to show this slide, the life cycle of my mind as it applies to the Zero Suicide Initiative. So just so that we can think about the overall goals of the initiative. So the very first step is for physician organization leadership to commit to the My Mind participation and recruit practices in behavioral health and primary care interested in implementing the zero suicide model. In the following year, recruited practices move to the next step of engagement by identifying site champions from primary care and behavioral health who will participate in our train the trainer model and champion best practices to their clinic. In the following year, participants will be tracking process metrics identified in the data collection strategy to develop a baseline of care from key findings and feedback provided by participants. And they'll also develop quality improvement activities and set goals to improve patient outcomes. And then finally, evaluation of the quality improvement activities will then inform the development of best practices for suicide prevention within the target population across behavioral health and primary care settings, and drive the identification of new initiatives for our collaborative. Next slide. Okay, so just to quickly touch on our peer recruitment criteria. So for our first initiative, Zero Suicide, we recruited POs to participate based on the following factors: a general interest and passion and need for support to support suicide prevention best practices within their patient population and region, some familiarity with the Zero Suicide model or integrated models of behavioral health and primary care. We also wanted to make sure that we're supporting a variety of independent and employed POs. And we also work with people who currently serve a representative sample of the state's adult population. And then finally, those who actively participate in the Blue Cross Blue Shield Physician Group Incentive Program with outpatient mental health specialty care and PCMH designation status for primary care. So at present, at the beginning of this year, we now have 519 participating providers and 101 participating practices. Next slide. So we're still a pretty new CQI, but what measures do we hope to capture? The data strategy table on this slide accounts for the 4 pillars of the Zero Suicide model, those being identification, patient engagement and care, treatment, and then care coordination. And over the course of the initiative, participants will evaluate how and where these elements are cataloged in the electronic health record, measure the number of individuals receiving these process measures, and finally assess the effectiveness of the initiative in improving suicide outcomes across healthcare systems. Next slide. And what is the role of the PO and our health system participants? So we like to focus on 3 key roles, which we've identified. The first is the provider leads, who represent either primary care or behavioral health, to the coordinating center leadership. The provider leads will work closely with the coordinating center to disseminate program information to practice participants, share updates on upcoming trainings for site champions, and work with them through performance goals. They will work closely with other PO leads within their organization to recruit practices from MyMind and share feedback with us, as well as attend our collaborative-wide meetings. In addition to that, we work really closely with all of our administrative leads from each of the POs who are responsible for coordinating program activities with practicing sites, and work very closely to recruit sites and disseminate any new information about our program. And just recently, we also added a new position to each of the PO teams, where we requested that they identify a quality assurance lead who will be responsible for data oversight, willing to provide feedback on process metrics during quality improvement activities, and also work really close with each of our site champions to make sure they're clear on what data measures we plan to capture. All right, next slide. So what is the role of the practice? So just one thing I want to note here is one thing that we like to really highlight is the importance of every member of the care team being involved in suicide prevention, and that we are happy to have anyone who is interested and engaged join our trainings. But key to this model working is really the role of these 2 people, those being the site champion and the administrative liaison. So in general, we define a site champion is typically a primary care behavioral health provider at a MyMind participating practice, and this individual will support advancing of best practices and communicate performance, quality initiatives, and educational information to other members of their practice. They also meet virtually with our team for training to identify successes and work through barriers at their sites. In addition to that, the practice team should also include an administrative liaison who works closely with PO leads and helps to administer the Zero Suicide initiative at the site. The liaison will communicate upcoming meetings, important dates, and share resources with their practice. All right, next slide. Okay, so just as a highlight from today's presentation, just a couple of things we wanted to make sure we hit home is that suicide is an epidemic with a death from suicide every 11 minutes or approximately every 130 every day in the United States. Suicide cannot be predicted, but risk factors can be identified in psychiatry. Suicide risk must be assessed at every encounter and modified whenever possible. The suicide risk assessment drives the treatment plan and the structure of the care model. And we do believe that zero suicide is achievable, and that we have an opportunity within my mind to be leaders in Michigan and also the world. All right, so just as a note here, the first would be our website. So that's an open source resource for members on this call who are also a part of our collaborative already. We have a partner portal, and that's how they are able to access that. Next slide. And then finally, I just wanted to highlight a couple of our resources that we do have. So our team has put a lot of effort to make sure that there are resources available, not just to primary care and behavioral health, but to any clinician. So a couple of things that we do have that now goes out quarterly is our newsletter. Our website also includes any of our upcoming events, as well as patient and provider tools. And then we have a video that explains a little bit more about the zero suicide model. Next slide. And then I would be remiss if I did not include the references for our presentation. So on that note, any questions?
Thank you so much, Heather. Does anyone have any questions for Heather? Can I ask a question to those on the call? From the sites that are here, I noticed there's a couple Ascensions, and then we've got Oakland. Do any of you at your institutions have any programs that are similar to this, or if you are participating in My Mind, or if any of the POs that you work with participate in My Mind, what is your experience with that? Have you seen any changes? Is there efforts in this area that are part of your quality improvement and, patient population care programs?
Hi, this is Eileen. I was going to start with just a thank you for sharing this. I am looking forward to when the video comes out so I can share it with the key members in the organization. I know our primary care providers participate in having CPC Plus, now it's primary care first, or the MIPS program, both in based. And there is a component of mental health is built within those programs, and screening happens, but I'm not sure that it's to the same level as what Heather was just speaking of. We could use what we've already started with that and build on it to then improve. So definitely looking at how we can start with where we're at and get better.
That's great. It's great to hear that there is a program in place. Thank you for sharing that, Irene. Ellen noted asked any tips for including local law enforcement within the prevention initiatives, given sometimes that police response are the first responders.
Oh, that's a great question. So I'm also I have two members of my team who do a little bit more of the direct patient care on the call as well too. So I am going to loop in Amanda if you could help us answer that question.
Yeah, absolutely. Thanks. So I think there's, a couple different ways. One is just being really familiar with the regulations within your county. I know, as a behavioral health provider, and we're virtual, so we provide care across multiple counties. The processes and policies change county to county. So being really aware of that is important. And I know my mind in general is trying to strengthen some of our connections throughout the state. We recently, actually just last week, participated with some police officers at a local area to try to get word out and understanding related to suicide prevention and what resources are out there. So while there is not a one size fits all, I would say just being really aware of the counties that you work in, what those policies are, especially related to petitions and certifications when it comes to behavioral health.
That's a great point. Thank you, Amanda.
Yeah.
Thanks.
Any other questions? I have a question from previous experience I have in suicide prevention. Is there any sort of focus within the program on specific populations, or is it of an overall, it's just we really want to get to zero? Of course, that's a priority, but I'm just curious if there's any focus on specific populations. What comes to mind for myself is I worked with a group who was working on veteran suicide prevention. So that's what I've been.
Great question, Chelsea.
Yeah.
So yes, the way that we are thinking about that is in two different areas. So one is with partnerships with different community-based organizations. So we, as a team, and welcome anyone to join us, have attended or have discussed information with the VA and local chapter here about how we could work together, even potentially put out some like joint information for veterans. In addition to that, we also attend some of the local Detroit Pride walks, and we will also be going to the Ferndale Out of the Darkness walk that is part of the AFSP's local chapter for suicide prevention. So that's a really good question. That's our first component, is the community engagement, how we can work at a grassroots level. And then in addition to that, our first year of training really focuses on understanding where organizations are currently at in their current suicide protocols, both at the clinic level and the organizational level. And then in the second year, we really think through, okay, how can we refine those practices with quality improvement activities. And then we talk a little bit more about vulnerable populations and how we can support those groups as well.
Fabulous. Thank you. If there's anyone on the meeting or who follow up and watch it afterwards, or hear from one of the colleagues on the call today that would like to get in touch with you, I saw that I will share the slide with your contact information. Is there any other guidance you would give to, perhaps like a hospital partner or a system level partner who would like to be more involved in this area and pursue opportunities to take on an initiative such as this?
Yeah, I think that's a really good question. One of the things that we just sort of note with our iceberg picture is that we recognize that everyone is in different parts of this journey, thinking about what our roles are in suicide prevention, and what parts that we take in that. And so I think what we would just do is to really think about, okay, what protocols do we already have in place, and realize that there are just some really simple things that we can do to support people and make sure that, those conversations that we have with patients, everything from that to brief interventions are things that are very doable. So if anyone has any questions about it, we would be happy to talk about it more. And we also wanted to make sure that a lot of our resources that we have for providers are also available on our website. So any questions about, some of our protocols related to lethal means counseling, safety planning, things like that, should all be easily accessible.
Excellent. Thank you. Is Sarah also noted if you have anything to ask and you think of it after the training, you are welcome to email the coordinating center, and the email address is mind@hfhshenryfordhealthsystem.org. Well, if there's no other questions, I'm happy to share that screen. Pull that up. There we go. There you go. And then the website is https:// www.henryford.com/mymind. And we'll certainly share those in the follow-up email as well. Thank you for sharing that.
Yeah, thank you.
Okay, I'm going to remove your spotlight so we don't have all that on there. Okay, so thank you all for joining us today. I appreciate everyone's participation. Thank you, Heather, for a wonderful presentation, very insightful and such an important piece of healthcare and our work that we do. If you are interested or know anyone who may be interested in participating in our next work group, our next one is going to be on health equity on October 3rd. Before that, we also have a special webinar review of a ED-based episodes report from MVC that was done in partnership with Medic, one of our other CQIs, that will be presented by Kristen Hassett, one of MVC's senior analysts, and Dr. Kocher, who is the director of Medic. So we look forward to seeing those of you who are involved in that on that work group. And then our health equity work group I mentioned will be with Dr. Alex Peel, who is assistant professor in obstetrics and gynecology at U of M and health services researcher. And then of course, our collaborative wide meeting, our next one is October 20th in Lansing at 10 a.m. We hope to see all of you there to have more networking opportunities and learning opportunities. It'll be a great opportunity to meet everyone face to face and get to know everyone a little bit better and see what's going on in other MVC participating organizations. So just to wrap up, thank you again. Thank you, Heather, and Sarah and Amanda. We really appreciate your participation. Today's work group slides and recording will be shared shortly. And if you have any questions, please don't hesitate to reach out to us or to the MyMind team. You're always welcome to provide feedback in the survey I mentioned earlier. And we look forward to seeing you at our future work groups.
Yeah, thank you.
Thank you.
And if anyone is interested in joining, we will be hosting a recruitment webinar in December. So feel free to reach out to us with any questions, and we'll make sure that you get that information. So
Fabulous.
Thank you, MVC, for hosting us. We appreciate it.
Yeah, thank you. Wonderful. All right, bye-bye.